This presentation covers the concept of perfusion, and we're going to talk about the exemplars of inflammatory cardiac disorders, beginning with rheumatic heart disease and going on and finishing up with infective endocarditis and myocarditis. Rheumatic fever is an inflammatory condition involving connective tissue in the body. Its most severe complication is rheumatic heart disease. This condition may permanently damage the heart valves and affect the flow of blood to and from the heart. Symptoms of valve damage often don't appear for 10 to 30 years after the initial episode of rheumatic fever. Rheumatic fever is a systemic inflammatory disease that's caused by an abnormal immune response to pharyngeal infection by Group A beta hemolytic streptococci. It's thought that the antigens from an abnormal immune response bind to cells in the heart, muscles, brain, and synovial joints, which causes inflammation. Damage to valvular structures may occur. Notice on this slide we also see other signs and symptoms of rheumatic heart disease, such as chest pain. You may auscultate a friction rub. This is a cardiac friction rub, not a pleural friction rub. Obviously, by looking at this picture, you can see that the leaflets of the valves cannot close properly, so we can have heart murmurs occur. This patient may also experience migratory polyarthritis. Other things are peripheral manifestations as well, and we will talk about some of those in future slides in this presentation. So rheumatic fever is a complication of Group A Streptococcus pharyngitis. Another word for that is strep throat. We've all heard of strep throat. The vast majority of people with strep throat do not develop rheumatic fever. That's the good news. However, in some people infected with Group A strep, the body's immune system not only fights the bacteria, but also attacks its own tissue, especially heart tissue. Risk factors for streptococcal infection of the pharynx include environmental and economic factors such as crowded living conditions, malnutrition, immunodeficiency, and poor access to health care. And there may also be a genetic component in susceptibility to rheumatic fever. So prompt identification and treatment of strep throat infections helps decrease the spread of the pathogen and the risk of rheumatic fever. You see in this picture the characteristic white spots in the back on the tonsils of patients who have strep throat. The importance of finishing the complete course of medications should be emphasized. Okay. Treatment, the goals of treatment are to kill the strep bacteria, to treat the inflammation caused by the rheumatic fever, to prevent future cases of rheumatic fever. Treatment should include antibiotics, penicillin or other antibiotics, including erythromycin, and azithromycin may be given to treat the strep infection. People who have had rheumatic fever are at high risk of getting it again. To prevent another bout of rheumatic fever, the patient may need to take antibiotics regularly for several years after the initial infection. A part of the treatment would include anti-inflammatory drugs, especially drugs like aspirin or NSAIDs, and they can help also with the joint pain and swelling. Okay, and rest is important, especially if inflammation is severe. The doctor could prescribe bed rest. or severe restriction of physical activity for a period of time. Promptly treating strep throat with antibiotics can prevent rheumatic fever. Okay, so if you or your child has a sore throat and a fever that lasts more than 24 hours, it is important to contact a healthcare provider. This shows an actual picture of the white patches in the back of the throat. They're tonsillar patches. You also see the inflammation here. And as a nurse, my first concern looking at that picture is airway. Could there be so much inflammation that the airway is obstructed? So it is very important to address the treatment with antibiotic use and anti-inflammatory such as our NSAIDs and aspirin. Okay. We already mentioned the antibiotics that are generally we would like to use penicillin. However, if a patient is allergic to penicillin, we can certainly prescribe erythromycin or clindamycin. The misuse and overuse of antibiotics is causing a major downfall in our society. Despite the instructions on the bottle, there are many patients who stop taking a drug when they feel better. The problem is what you see on this slide, the creation of a superbug, a bacteria that is resistant to many, if not all, of the antibiotics that we can attempt to use to eradicate this bacteria. And this creates a huge issue for scientists who are forced to create stronger and stronger prescriptions. The bacteria which are causing the illness mutate to accommodate the antibiotic if the prescription is not used to its full extent. When patients misuse antibiotics, they're putting the world, our society at large, at greater risk for infection because the bacteria simply get stronger and more resistant to the antibiotic. The select few bacteria which survive reproduce and create more of their own resistant kind. That's why it's always important not to skimp out on the full course of antibiotics that is prescribed. While true, the people who get heart damage, it's usually decades after having strep infections, but that is not always the case. And so this slide does show us a range of ages in patients. The first one I put up here is Patsy Cline. I don't know if anybody recognizes her. She's a country music star. She died tragically in 1963, but she had several close calls with death in her life. Her first brush with death was a serious case of rheumatic fever when she was 13 years old. And it was after this, that illness, that somehow she says, this is a direct quote, "The fever affected my throat, and when I recovered, I had this booming voice." Okay, so we saw the inflammation that occurs, and that's the damage that was caused. It worked to her benefit in her case. But why I chose this picture and this story is because look at how Patsy Cline propped herself up, leaning forward, assuming a tripod position with 3 pillows. Okay, so when she's doing that, that's an indication that she has difficulty breathing. Remember, when the cardiac valves are affected and cardiac output is diminished, they're going to have trouble breathing. So she is assuming this position, and that's a big indicator to you. Yes, it relieves, it allows her chest to expand, and it relieves her shortness of breath. But this should be an indication to you that this person is having difficulty breathing. And we see over in the other picture a young girl, it's an 11-year-old, okay, and she is actually in a doctor's visit because she has had to have an artificial valve placed. It was inserted after she had a bout of rheumatic fever, which damaged the heart valve when she was just 7 years old. Because she got a mechanical valve, artificial valve, she can even hear it opening and closing. When it's very quiet at night and she's relaxing, sometimes she can actually hear her new valve operate. Okay, and that is exactly what we have with our artificial valves, our mechanical valves. And of course, she's having an echocardiogram, so we can just repeat that we know patients get echocardiograms when we want to look at the function or structure of the heart. In this case, he's going to be looking at the mechanical valve, the structure, making sure that it is situated properly and how well it is functioning in that young girl. Okay, now we're going to be talking about infective endocarditis, frequently abbreviated in our charts as a capital I, capital E. You have to know that stands for infective endocarditis. It is an inflammation of the endocardium. As you remember, the endocardium is that inner lining of our heart. It is generally infectious in nature and results in colonization of the cardiac structures by a pathogen. Development of endocarditis requires entry of pathogens into the bloodstream. Vegetations of pathogens form on the cardiac structures, most commonly the valve leaflets. As these vegetations grow, they interfere with normal movement of blood through the heart. The vegetations may also fracture and embolize. Remember, embolization is going to be traveling, then it can travel through the bloodstream. Now, prosthetic valve endocarditis occurs in patients who've undergone valve replacement surgeries. And they may develop it early in the postoperative course due to contamination of the prosthetic valve during surgery or perioperative bacteremia, and usually it has a rapid course with high mortality. Risk factors for infective endocarditis include the presence of congenital deformities of the heart, tissue damage due to ischemic disease, valve prosthesis, intravenous drug use, invasive catheters, dental procedures or poor dental health, and recent heart surgery. Education of susceptible people is a key part of prevention. Clients with pre-existing heart valve damage or replacement may require prophylactic antibiotic administration prior to invasive procedures, including routine dental work. Okay, so there are many risk factors, but let me tell you the typical picture that we see in almost every semester, and I think we've already seen one this semester, and we've only had one clinical day in my group. The first clinical group already experienced this very typical pattern. We have a patient who comes in, they're a IV drug user, okay, and with the large population of indigent patients that we have at Tampa General, it's no surprise that we do get patients who are IV drug users. But the problem is that the pathogen enters through the bloodstream, and they love to go to the heart, to the endocardium and those special leaflets of the valves and set up shop there. They begin to grow and produce this bacterial vegetation. Okay, so that is very very common story that you will hear with patients. Unfortunately, a lot of times the IV drug users don't stop using IV drugs, and even once they've already had cardiac valve replacement surgery, they continue to use IV drugs, and they can have this happen repeatedly where they have endocarditis and must then have another valve replacement. It just depends on really what type of valve they get as well. Okay, so before I go any further, let me go back because I have a note to myself to make sure you understood in that last slide that we can prevent endocarditis in patients who are at risk of it by administering antibiotics prior to procedures. And I did mention it, but I just want to stress that to you, that that's what we do, even though they don't have it, but because certain procedures would increase their risk of getting it again, we go ahead and administer antibiotics before the scheduled procedure. Okay? So here we are. And it's just another beautiful picture of endocarditis. We see the infected part of the endocardium in these pictures. You can see the actual clumps or vegetations of material that grow from the infected valves. This vegetation contains bacteria, some blood, really small blood clots, and other debris. Okay, they're shown here on the aortic valve, but they can occur on any infected valve. Okay, not just one side of the heart, or it could be anywhere where there's endocardial tissue. Okay, when that patient goes down for an echocardiogram, it's not uncommon at all, especially if they have infective endocarditis, to visualize these vegetations like flags waving in the bloodstream as the leaflets open and close. So there again, you can see a structure, even a structure such as a clump of bacteria growing on leaflets with that echocardiogram. Now, there are different signs and symptoms, manifestations of infective endocarditis. And the ones that we're talking about here are the peripheral manifestations. Okay, before I go into detail about those, understand that other signs and symptoms of endocarditis can be very nonspecific, such as they feel like they've got the flu. They may have chills and fever. Imagine if you have a pathogen in your bloodstream. Okay, they can have a general malaise, fatigue. They can even have a cough or dyspnea and joint pain again. And there's also that often present is a murmur, a heart murmur that we should be able to pick up on. They could even have anorexia and abdominal pain and even develop splenomegaly. But the test questions in nursing frequently are directed at the peripheral manifestations. That means these are changes in the skin for the most part, except for here the retina is one, but where you can visualize these changes. And they include splinter hemorrhages, okay, those of the nails. You can see them there. It's not because you had a small trauma to your nail and injured the nail bed. No, this is different. There was no trauma, but we see the splinter hemorrhages because of the infective endocarditis. Okay, a big clue right there. And then another one we see to the right there in the picture, the ossular nodes on the finger and toe pads. Okay, remember these are on both the pads of the fingers and the pads of the toes. Okay, they could be. Below that, you'll see the Janeway lesions. These are on the palms and soles of the feet. Okay, so we see in this picture simply on the palms. Okay, and then finally over here on the left, this is looking into the retina of the eye. We see these very unusual spots called Roth spots. Now, Roth spots would be another finding that would suggest that the person has infective endocarditis. Okay. How do we treat infective endocarditis? With a prolonged course of antibiotics. Antibiotic therapy effectively treats infective endocarditis in most cases. The fibrin covering over the vegetative lesions protects them from antibiotics. So therefore, it requires a prolonged course of therapy. That means that these patients are going to need, for weeks, sometimes like it could be 6 weeks of antibiotic treatment. Okay, so they're going to need some type of IV access that's going to allow for continuous infusion of antibiotics. Okay, these are intravenous antibiotics. Okay, that's the only way you're going to treat this, is if you have intravenous administration of antibiotics for periods of weeks. Okay, sometimes that patient is in the hospital, but they could be sent home with a central line, for example, or a PICC line, and they can have their antibiotics administered by a home health nurse. But again, that would be pretty dangerous, especially if your patient got infective endocarditis because they're an IV drug user. So that wouldn't really be a wise decision for that patient. Antibiotic therapy, as we said, is generally effective. Without treatment, endocarditis is almost universally fatal. Okay, remember there's that common complication of infective endocarditis, which is the embolization of vegetative fragments, okay, as well as the development of heart failure because of the destruction of those valves. Let's mention real quickly here, the nursing diagnoses related to infective endocarditis could include risk for imbalanced body temperature. Sure, but this is the big one that we're looking at today, is certainly the risk for ineffective tissue perfusion. Remember, when there's cardiac valvular disorders, they lead to ineffective tissue perfusion. And certainly there's ineffective health maintenance, especially with our IV drug users as patients. Okay, moving on from infective endocarditis to our new disorder we'll talk about is myocarditis. We're going to touch on all 3 layers of the heart that we talked about earlier in our A&P review. Now we're moving to the myocardium. So this refers to inflammation of the heart muscle. Myocarditis usually results from infection, but most commonly the infection is viral in nature. Okay, so a viral infection is what it's usually the result of. The extent of muscle damage ultimately determines the long-term outcome of the disease. Severe myocarditis may result in cardiomyopathy and heart failure. Myocarditis is often preceded by a very nonspecific febrile illness or upper respiratory illness. And the signs and symptoms often appear similar to those illnesses. We can see with myocarditis the development of a pericardial friction rub. We can hear murmurs. We can hear an extra heart sound, an S3. That's your ventricular gallop. And it can even cause chest pain in our patients. Risk factors that can lead to myocarditis include things that alter the immune response. Well, right up there is advanced age. Our immune system is affected as a natural change, part of aging. So advanced age would be a risk factor for this. Malnutrition, alcohol use, any immunosuppression, and we know there's lots of things that can cause immunosuppression in our patients. Exposure to radiation and stress. All of these things could increase the risk for myocarditis. Okay. Medications administered for myocarditis depend upon the likely causative factor. Common medications include antibiotics and antiviral therapy if infection is the cause. Now, I know this sounds a little contradictory, but it is the state of treatment here. Immunosuppressives may be used to minimize the inflammatory response if inflammation is a factor. Okay. I know it seems strange that immunosuppression is a risk factor, but it is certainly always a treatment too when there is an inflammatory response. If the patient has heart failure as a consequence of this, they're treated with ACE inhibitors and other drugs, but they would probably not use digoxin. If they did, they would use it with caution. Okay. Other medications would include antidysrhythmic agents. And by that we mean there's a whole slew of drugs that are classified as antidysrhythmics. Okay? They prevent electrical conduction problems as a result of this inflammation. Now, wouldn't you imagine if that the myocardium, the muscle of the heart itself, is inflamed, that it would be a little irritable and perhaps could lead to electrical conduction problems? That is exactly the case. So they may give the patient a medication that prevents the development of arrhythmias. As well, we have to think about anticoagulants may be used as well. Let's see, is there another slide? Maybe not. So I'll go ahead and mention briefly some nursing diagnoses to include for myocarditis would be activity intolerance. Okay? Decreased cardiac output. Those would be the two big ones, okay? And since we're studying perfusion, you have to understand that this could lead to decreased cardiac output. Others include fatigue, anxiety, and excess fluid volume, especially if they develop a heart failure. Okay, we're going to continue on with part 2 in the next presentation.